I'd like to thank all the presenters because they were really good about sticking to their time limits. Thom Eisele will be leading the panel discussion, and Thom is a professor in the Department of Tropical Medicine at the Tulane School of Public Health and Tropical Medicine. He's also the director of the Center for Applied Malaria Research and Evaluation. His research has focused on malaria epidemiology and evaluating malaria control and elimination strategies, and particularly looking at mass drug administration, for example, in Zambia and Haiti. He's a member of the Rollback Malaria Monitoring and Evaluation Reference Group, as well as a member of other expert groups in the area of malaria. So I invite Thom to come on up, and the other speakers as well who are going to participate in the panel.
Thank you, Cindy. You make me sound competent. That's very nice. Yeah. So I'm gonna help moderate this session, and we have two panelists that are going to join us that have not been introduced yet. Many of you might know them, Fred Arnold and Shane Kahn. Fred is the Technical Deputy Director at the Demographic and Health Survey Program at ICF, which was just refunded, I think, for another 5 years. So, and then Shane is a statistical specialist on the multiple indicator cluster surveys at UNICEF. So what I would suggest is this is your time. If you have any grievances, gripes about the surveys, you've got Shane and Fred here that you can really ask pointed questions. So this is a great opportunity. But no. Thanks again for the panelists, for the panelists and those presentations. If I might ask if people are going to ask questions or make comments, if you just let us know your name and what organization you work with, that might be helpful. And I think we haven't had a coffee break yet, so if people want to sort of go back and get coffee, I think that's quite okay.
Yeah.
Maybe I could start us off by asking Fred and Shane, in their perspectives, relative perspectives from their institutions that deal with these big household surveys, two questions. One is can you give us an idea of how these validation studies done by this group have been helpful in improving or adjusting the way that the survey questions are asked or indicators? And then secondly, are there particular areas or questions or indicators that you feel that would be helpful if this group were able to, or other groups were able to, do some validation work around them for help improving them?
Okay. Yeah, thanks. In the collection or supplement, we do give some examples of how these validation studies have been used in the past in DHS and mixed surveys, and not just in terms of modifying the questions, but in terms of modifying the standard tabulations and the analytical approach. So we have found these to be extremely useful. I would say at present, there are so many now, not just the ones that were done by the core group, but so many other validation studies that are available. They're really crucial to upcoming activities, which include a thorough review of the DHS-7 questionnaires and a modification of those questionnaires for the DHS-8 program. And we also just came out with a maternal health care module, an optional questionnaire module. And for putting that together, the starting point was to review all of the literature, all of the validation studies. So we determined up front which particular indicators were not well validated and should not even be considered when putting together this module, and which ones were well validated. So in that sense, all of this information that's coming out of these studies is extremely useful to us. And I believe that module is now on the DHS program website. If not, it will be very soon. And we are going to have an open portal for people to give their suggestions about changes, additions, deletions, and question changes to the DHS questionnaires, the model questionnaires. And we hope all of you will give us your suggestions. And above and beyond that, all of these are viewable by the public, so anything that somebody puts on there can be viewed and commented on by other people. And I've already been told this morning that some people are just waiting to do that because they don't always like what people are suggesting, and they want to weigh in on that as well. So we take both the suggestions and the comments on other people's suggestions into account.
In mid-January.
Mid-January, for about a month, that portal will be open.
Okay, from the side of UNICEF, I have to say congratulations to this group. We've been working with them for a number of years, and these validation studies, they really are state-of-the-art pieces of work that you can really look at for different kinds of rigor. The validation studies themselves, they're one kind of evidence that we would look at from the mixed program to move forward in terms of taking up evidence, in terms of considering how and if to trigger changes to questionnaires, tabulations, how we interpret the results. So this is one of the very important pieces that we do look at, and we take it in conjunction with other things as well. Unlike the DHS program, we don't necessarily have, we don't have a contract with anyone. It's UNICEF's own program, so we don't have a specific time to do these kinds of revisions of the questionnaires. We do them on a more ongoing basis, specifically through different communities of practitioners. So this one would be on health, where UNICEF would organize meetings with different parts of the health community globally through different organizations and different interest groups, and then they would tell us, or they would make recommendations to us about what needs to be measured next. So I think answering Thom's question on what indicators need to be worked on next, I think we'd look to other kinds of groups that are interested in different kinds of health and nutrition data that this group is already working on to provide some kind of guidance. From our side, we do a wide range of indicator development and indicator testing, including cognitive testing, focus group testing, observations structured in the field. And we will be doing another field test for mix coming up in March of next year. We will return to Belize, which is one of my favorite testing grounds at this point. I can easily get to it. It's a good mix of respondents, who speak English and some that speak Spanish, different cultures, different socioeconomic levels. So for me, it's sort of ideal in many ways. But we'll start testing very new things for mix, such as children's time use, which is of interest to UNICEF. Are children overcommitted to different things or undercommitted? It would help us explain certain things that we do see in the mixed surveys. Why is school attendance so high, but learning outcomes not so great? So if we knew more about the time children spent on studying in school, we can attribute some of that to this. So in that exercise, we're going to do quite a lot of work on cognitive interviewing, finding out how people understand different questions that we are coming up with right now, and perhaps some comparisons to other tests, other more gold standard-ish measures in the field to be determined.
Thanks, Fred. Thanks, Jane. Fred, one question. So when the solicitation for recommendation and comments for the questionnaire for DHS, does DHS release a statement on what they've accepted or what their plan is for after they've gone through all the sort of recommendations?
Yeah, I mean, we're discussing that. Obviously, the new questionnaires are released, and it's pretty easy to figure out what's changed. In terms of providing a rationale for every single thing, that would be a bit challenging, I would say, because we get hundreds and hundreds of suggestions, and then if you say, well, this didn't make the cut because of A, B, and C, it's almost like you're trying to find a reason. You know, there are so many good questions out there, so many important topics that you would like to incorporate, but there's just not enough space. So we are discussing how to do that and give people a sense of why certain things were included or not. And I think one way of doing that is to give people criteria up front. Say, these are the kinds of things we're going to use as considerations in the decisions to make changes, so people have an idea of what they should focus on when they give us their suggestions. Because we do carefully go through everything. We have internal working groups on each of the topics, and then eventually it goes to a overall questionnaire design committee. And I would say that we're not only looking at the core questionnaire or the model questionnaire, we're also looking at the optional modules this time and asking people for their suggestions about the optional modules.
Okay, thank you. That's helpful. So we have about 30 minutes. We have the room till 11, so I'm going to open it up now for comments and questions.
This is Madeline Short-Babick. I'm the team lead at USAID for the DHS, so I'm also intimately involved in these conversations that Fred was discussing, and I just wanted to chime in with maybe a couple of additions. One is the plan this year is indeed to have just a list of what changes were accepted and the rationale for those changes. So like Fred said, we're not going to have an exhaustive list of every single thing that was put forward and the rationale as to why it was or was not accepted. But for the changes that were accepted, we are planning to have a document for the public that gives the rationale, et cetera. Along within the, Fred said criteria, I would call them sort of guidelines. I think that I'm imagining many of you are interested. The plan is to send that out with sort of a save the date in mid-December, but I think a lot of them will probably align really well with the updated DHS Guide to Statistics. Please utilize this amazing resource. No, it's fantastic. It's beautiful. It provides numerator, denominator for every indicator that DHS reports, as well as a description of how it's changed over time from different DHS phases, as well as a brief list of research that supports that indicator or gives some additional nuance to the indicator. Anyway, it's great. Thanks, Fred et al. For doing it, because that was a big task. I'm going to stop there, even though one last thing, future validation work. Coming out of the core questionnaire revision, there will be a whole set of ideas for changes, modifications, questionnaire modules or the like that haven't been well validated, but that doesn't mean that they're not really great data collection ideas. And I hope that we could revisit that question some point later in 2019 as to what those pieces of information are, if there's an interest in this group and continuing this sort of work. So what popped into my mind, for example, is mental health, and there's a lot of interest in mental health, but I haven't seen as much validation work in the context of population-based household surveys.
Maybe there might be some validation work that's done, not in surveys, but in questions that are asked in higher income countries, for instance.
Yeah.
just maybe to respond, you sort of jogged my memory a little bit about future validation work, and one of the things that we're developing at Mix is a criteria for inclusion in the Mix surveys and what goes into the actual questionnaire that we would recommend to countries. And part of that has to do with if this is an SDG indicator or not, if this is of high UNICEF priority or not, the level of country interest that we get. So that's part of the criteria that we will come out with, which means a lot of the validation work that we will be involved with would have to, by definition, be inclusive of those criteria. So we'll put our money more around those indicators that meet the criteria than anything else. In terms of mental health, at UNICEF, there is a huge push right now for improving adolescent well-being, and mental health is part of the well-being. We've already had one expert group meeting on mental health thus far, basically to find out, can this be done, should this be done even? And I believe the results more or less said that it's an all right thing to be done, but not necessarily asking people about depression and their symptomologies for different kinds of mental health issues, but something a little more distal that we can actually get to with programs. So that's the direction that the mental health work is going with at UNICEF. Whether this will be a core part of Mix or not remains to be seen, because that will depend on our criteria again for inclusion. But it is something that us as household survey specialists at Mix will be supporting in terms of the development.
Thank you. Do we have other? Some back there, yep.
Hi, I'm Kate Gilroy from MCSP Child Health and MMEL teams, and I was just curious, given Melinda's presentation and also some of the issues around measuring pneumonia treatment and things, in the global space, is there thoughts to harmonize, say, the SPA or SARA or the new WHO harmonized health facility assessment with the household survey cycle and kind of make these measures more mainstream for the high quality coverage or, effective coverage?
I can try and answer, and maybe Fred can answer the question about syncing up timing cycles. But one thing I wanted to say in response to that is that I think that we don't have a great sense yet of how much of a problem it is that we often are linking household surveys and health facility surveys that may be 2 or 3 or more years apart. Right now, people are doing that, and I think we have questions, right, about what the impact of that is. And we do want to look a bit at we think that quality of care measures are not particularly stable over time. And so we want to do a little bit of work on that, but to understand, does it really need to be at exactly the same time? Is 6 months difference okay? Is 2 years okay? So I don't think we know yet. But I'll let Fred answer the question about what, sort of trying to sync up the timing of DHSs and SPAs.
Yeah. I think it's challenging in two senses. One of them is simply a funding question. If a lot of the funds for these different types of surveys are coming from the same providers, that it's very difficult for them to say, okay, in this year we're going to do both a DHS or Mix and a SPA survey. So there's that. And then there's all the timing issues about the indicators themselves, the ones that are within the last 2 weeks, childhood illness or symptoms of childhood illness in the last 2 weeks. That's going to be very different from some of the antenatal delivery and postnatal care questions that are over a 5-year period. So on average, those would be 2.5 years ago. So if you're going to be offsetting them, at least for those measures, it would be good to have a SPA survey or a facility survey a couple of years even before a DHS or Mix.
And that's something we wrestled with when we were testing these methods, is that you can't, if you're interested in doing linking for both child health and, say, intrapartum, those are 2 different reference periods, and you can't have one facility survey that works for both.
Well, that's why USAID just needs to fund SPA and DHS
Yearly
surveys
spas.
every year, right? And then we could mix and match as we need. No, kidding.
A question for Fred. Has there ever been discussion at DHS about, as far as, when you look at the maternal health section and they're looking at births, say it's been births in the last 5 years, births in the last 3 years, last live birth, there have been various ways of cutting that off. But, when we were talking about the pneumonia, that's kids been sick in the last 2 weeks, and obviously there are huge sample size implications to that. But have there been discussions within DHS ever about cutting the births off, say, for the last year? I'm just trying to think, questions about did somebody talk to you about some green leafy vegetables 2.5 years ago in an antenatal? None of us could do that, and yet we're paying, somebody's paying to ask these questions.
Yeah, well,
No, I know, it's gotten better than that, but, no, my question is, though, has there ever been discussion about really shortening that period for births?
Yeah, thanks, Cindy. Yes, we always discuss these things. It comes down, one thing obviously is the sample size. And if you cut it down too much, you get a smaller sample, you get wider confidence intervals. And then particularly if you're looking at changes over time and you want to look at the trends, you have confidence intervals on both of the estimates, which make it much more difficult to say what's happening. On the other hand, we think the quality of the data could probably be enhanced by cutting it back and not getting information for 3 children the woman might have had in the last 5 years, and she will find those questions to be quite repetitive. We don't ask about green leafy vegetables more than the last 24 hours, so I don't think we want to cut that down further.
Maybe to add to that, there has been some good analysis and methodological work on reference periods for maternal recall on those issues. Basically looking at if you cut down from 5 years to 3 years to 2 years, we use in mix, and there is some difference. So I think this is something that we sort of all know, that the estimates do differ if you cut down the reference periods. At least for UNICEF with global monitoring, we reanalyze all of the data to have a common reference period that we can look at over time. So that's one of the things that everyone can do. It's not just us. The data are out there, and you can do that kind of analysis for yourself too. So you can come up with those kinds of trends as well from DHS data.
So you're saying that we know when delivery happened by the age of the child, and so you could actually do that yourself by categorizing how long ago the woman delivered. So you could actually compare those that are recalling for a live birth in the past year versus a live birth in the past 2 years.
2 years, yeah.
Yeah.
And just a footnote, I guess, I think you can also do it differently in different countries. If you have a small survey of 7,000 households, that's one thing. If you have India with 602,000 households, you've got a pretty big sample size, and you can cut that down into shorter segments.
But you can do that, correct, Fred, without having to limit how far back you go. You limit it to birth in the past 2 years, but you can, if you have a big sample like in India or in Malawi, you can actually look at that just in the past year and limit it to that.
Sure.
Yeah. But you also come up with bias of higher fertility women, etc. So that's...
Other comments or questions for the panel? So maybe a question for, well, Mickey is not up here, and Emily, but so I know it's a follow-up question to the fact that in this part of Zambia, which I know very well, it is really dominated by the public sector, and there is traditional practitioners, but there's not a huge private sector. Do we think that it's worth redoing this study in an area, West Africa, I'm thinking, or Nigeria, if you dared, which would be a challenge? And to try to get at a more dynamic provider landscape that has more private sector. 'Cause I think that's going to be a lot different story as to how well women are able to recall care seeking and where they went.
Emily's pointing at me because I work in West Africa.
Yeah.
India.
Oh,
and India as well,
Yeah.
because
Yeah.
and we didn't hear that presentation. It's quite nice. Andrew had done that in India.
Oh, yeah.
But but there, I think I'll let you comment. But there, I think it's just the methods are hard because it's hard to track where people went.
Yeah. Do you want to respond about India, Harry?
We explored a way of trying to capture the large variety of different healthcare providers in India by putting an app on mothers' phones and making a census of all the health providers and their GPS coordinates, and then using that to identify care-seeking episodes. And we thought that would help us to identify private providers and pharmacies, for example, that might not agree to take part in a more formal study. And I think that in summary, it's a work in progress. There's a number of technical issues that need to be dealt with, and we didn't solve all of these in the study, but I think that approach is certainly one potential approach in the future.
But it was considerably more complex, right,
Yes.
than in Zambia.
But Harry, so I've seen the presentation and the paper on the methods for doing this. The results were challenging to interpret because of the challenges with matching getting the gold standard correct. But are there, can you remind us if there are particular results that would sort of diverge from what was found in the Zambia setting?
I don't really think we're clear enough about the results
Okay.
to be able to say that with any certainty. Yeah.
So this might be an area of that needs replication in perhaps having thinking about how you would actually capture that gold standard, which I think is one of the big challenges of all of these studies, is trying to capture that gold standard of observation.
This just made me think about some of the work we were doing around care-seeking behaviour with women with preeclampsia, and we found that they go to up to 11 different providers. So which one do you count for that actually gets the treatment? I mean, they may have got some kind of care in some of them, but they kind of go back and forwards. So I just kind of thought off the top of my head what you would do about that.
Hi, no, I just wanted to reiterate that Lara Vaz, Save the Children, SNL, and then also MCSP, MMEL. But with just everything these days, keep it going. But with newborn and care seeking for newborn, we're also seeing care being sought at through multiple providers in a really short time frame, and oftentimes treatment initiated in one place and then continued. And whether that treatment is the same across the providers also is something to take under consideration. And I think it is it's equally important for what we're seeing in pneumonia as it is for PSPI. So.
Yeah, I mean, I think I think we've noted that these studies are easier to do in simple care-seeking environments, and to be rural West Africa looks a lot like rural Zambia. So there are large parts of the world where there is not much sequential care seeking, where people mostly go to the public first level facilities. But there are also large parts of the world where that's not the case. And so I think that is the next question: is how well do these questions work, or do these methods work in complex environments? And you heard from Harry that trying to validate even care seeking for sick kids, which is a lot easier than actually care seeking for newborns, in India was a significant challenge. And the paper's in the supplement, so you can read about all the challenges of that study.
But maybe to, I work with a lot of groups on varied indicators across many different sectors, and I think the one thing that all groups have in common is they want to know a lot.
Everything.
And we want to know everything. We would like complete ethnographic studies and data on all topics at all times. And obviously that's not possible. But I think you raised a good point. It's like, well, people do different things, but my big question always to all groups are, what is most important for you to know? And then we have to look at it and see, is this possible to find out from a household survey? Something that we've studied here, we know that we should probably just get it from a health facility, and we should be scaling up facility surveys or administrative health management, health information systems within hospitals and facilities. So I think the first question is really the important one. What is most important? And that comes with it's a bit of a loaded answer. It might be most important to you and 2 other people in the room, but to 5 others it may not be. There has to be a lot of literature behind it that says that this really is an indicator that makes a difference for us children's lives or women's lives. So there has to be a lot of considerations and thoughts behind answering that question. So.
Okay, did you?
Yeah, I was just going to add that in the validation analyses that we're working on now, we're hoping to disentangle. There is data on, is this for postnatal care for newborns and mothers? Is this the first time that you're receiving postnatal care, or is it a follow-up visit? So hopefully we can disentangle, does reporting accuracy differ by, is it repeated PNC or the first time? And as others have mentioned, and we've also tried to look at prior parity, and is it the number of births you have, does that influence recall accuracy? For parity, we haven't found any clear trends yet, but we continue to explore it. So I think it's important, to keep in mind.
Any other comments? Well, I had a question going back to your talk, Kate, was thinking about, and maybe this is a question for the whole panel, but thinking about all the issues with accuracy of recall of what happened during labor and delivery. Is there an alternative way of measuring that we think, should those questions be dropped, or what would be the most important limited number of questions that we could ask that would get at indicators that would sort of do the job or at least satisfy what we need to know? And are there other alternative ways of collecting those information?
That's a great question, and others, please feel free to chime in. But I think that things people really want to know about what happened during labor and delivery, like did you have a uterotonic within 3 minutes of birth? We can't get that information from women, I don't think. So I think we need to come up with another way of, getting it at the provider level, the facility level. It's a continued challenge. Things that women can report on, I think we've seen from our data that it tends to be, physical things that actually concrete, observable health checks in an atmosphere where the woman's actually able to recall, kind of code into her memory what happened, and she's aware of the interventions that are happening to her. So I think a lot of the interpartum care and things that really matter for maternal health maybe better be able to be reported at a routine PNC visit versus that interpartum period.
Maybe to add to your question on new methods to collect data, we at the Mix Surveys, we just launched a new initiative. It's a new project of Mix called Mix Plus, which is basically a rapid mobile phone surveys that follows up Mix respondents. So after a Mix survey has happened, we of course ask people for their phone numbers and contact information and consent to call them or get in touch with them. And we follow them up for an extended period on a fairly high frequency basis. So this, for us, is going to open up a number of possibilities about how we can track different indicators. We have a lot of interest from UNICEF in terms of polling and program coverage, but for a group like this, something like child illness asking about in the last week, if we call parents every month, for example. That could be particularly interesting to see what reference periods do or what they don't do. So it's a fertile testing ground, but it's also going to be a very useful tool for monitoring at different levels. We do not intend for this to be a panel of representative data of all of the mixed questions. That's not what this is. This is a much more flexible tool, but we will come up with panels of individuals with different needs, and each country will end up doing something quite different. But it's very exciting for us. So this is the new project going ahead. It doesn't replace MIX, of course, because the amount of data and the kind of data you can get from MIX and from a mobile phone survey are very different things. But it's something that will give us a new way to reach people faster.
Do you have any examples of what types of questions or indicators you would try to get longitudinally from mothers following a mixed survey?
Just like everyone in this room, I want everything.
Are there key priorities that you want? I mean, some things wouldn't change that fast, so you wouldn't need longitudinal data all that frequently. But there are
correct.
Yeah.
Yeah, and so one of the first exercises that we are doing right now is to go through the mixed questionnaires to see what are the things that would be most useful to ask on a high frequency basis. And that's an exercise that's sort of ongoing, and we will have to have something by March, more or less, to test out. But we are also using this very, very much as a way so countries can really tailor this to their needs. So in Belize, they have certain programs in certain areas that they would like to get some estimates of coverage within those areas. So that's one thing that we will look at. So the field is sort of wide open at this point.
I can think of a few.
I'm sure you can.
No, but if you were able to identify pregnant women, you could ask a whole series
follow-up
follow-up questions on ANC, which is really challenging to get 2 years later. You could definitely ask about net use among pregnant women and about their children.
And we can do this qualitatively as well, by the way. So we don't have to have just yes or no answers. If we call them on the phone, we can find out a lot of qualitative information that we just won't get. So one of the big questions is why, if ANC services are available, why don't women use it? Same thing for skill delivery in different places. So it does open up many, many possibilities for us. And we have to link this strategically into programming. That also includes crisis and emergency monitoring as well.
Yeah, super interesting. So we still have another 5 minutes before they kick us out, I think. Any other comments or questions for the panel? Or anything the panel wants to add?
I had a question about the linking of the household survey and facility survey data and how you're assigning the quality scores to individual providers. And it looks like you have kind of a mix of the readiness data and the observational data. In some cases, you have both for certain interventions. In some cases, you just have one or the other. Mm-hmm. So I'm wondering, how that factored into your quality scores and kind of maybe what assumptions you made if you only had readiness data and not observational data. I also saw one of your health facility assessment sources have vignettes and sort of case scenarios. And do you look at or consider the usefulness of vignette data and assigning your quality scores? And I saw the World Bank SDI study is not one of your data sources. I know they use vignettes, and I was wondering why that didn't meet your criteria.
So for the linking studies, I think maybe to start with the last question, we only used facility data that we had collected ourselves because we wanted the facility data to be collected right before the household survey. So we kind of had, and from a census of facilities. So we had to use our own data. So the methods were a little bit different in the two countries and also by service area because of resource constraints. So in Zambia, where this was really an add-on study to the care-seeking validation study, we just did readiness. And so we did no observation of sick child care in Zambia, and we used vignettes as a way to try and estimate provision of care, but we know they're not. Well, we think they're not great. But actually, one of the things that is on our list is we have some data from other studies that will allow us to compare for the same facility or same providers vignettes to observation. In Côte d'Ivoire, we collected process and structure data for all service areas, for all facilities except ANC. Except ANC and intrapartum. Sort of with an asterisk for his intrapartum. So we collected structural quality for all service areas. We did not collect process quality for ANC because basically we had limited resources, and ANC was sort of lower priority in terms of life-saving potential. For intrapartum care, because observing deliveries is very difficult and very expensive, we had wanted to do it, and we just didn't have the funds to do it. We used a module that was developed by IDEAS, the IDEAS project at LSHTM, where they interview providers about the last delivery that they attended, and they ask them questions about what they provided, what happened during that delivery. So not as good as observation, but maybe a little bit more than readiness. But that's, so the reasons why you see sort of differences between service areas in terms of whether we had structure or process data is just related to resources. But within those service areas, all facilities got, so for example, within ANC, all facilities in Côte d'Ivoire got a readiness estimate. None of them had none of them had process quality. Within sick child care, all of them had both. And then we did the linking separately for process and structural quality, so we weren't sort of worrying about comparing apples and oranges there.
Thanks. Okay, I think we're almost at the end of the hour. I want to thank everyone for taking time out to join us this morning from your busy schedule, and thanks to the presenters and the panelists. Big thanks to Melinda for leading this whole endeavor.
Well, thank you. I also want to take just a moment to thank all of you for coming, to thank all of the core group members, everybody who's presented today, and also our organizers, Brittany Fergal, who's standing in back, and Monica Fox at the back table for all their efforts in this work. Okay, thank you.